So, as Alice said, welcome everyone. We're very glad to have you here today, and I hope that many of you are patients and their caretakers or partners, because many people with dysphagia don't need people taking care of them. They just have partners that they live with. So I hope that we have a broad range of people with us today. We are focusing this webinar on patients and people who live with dysphagia. So to get ourselves kicked off, we're going to do just a little bit of an introduction, and we're going to start this introduction with Eric. So Eric, I'll let you take over and introduce yourself.
Hi, my name's Eric. Just a disclaimer about that photo. That's not a person's house on fire. I'm not taking photos in front of people's houses. There was a controlled fire that we were able to train in. So, obviously, before my stroke, I was a firefighter, really fit. I was doing that for about 12 years. And then I had a bunch of strokes. I thought life was too easy. I thought I'd have all these strokes all at once and enjoy that. Obviously, my life just turned upside down from that. I lost um, not a lot of things that I lost. Things that were obvious. Obviously, my career. My I lost friendships, broke up. But swallowing was the one thing that was always the dark cloud that kind of fun police. You know, when you're depressed or stressed, you eat a tub of ice cream or a bucket of KFC, but I couldn't do that because I lost my swallow. And so as I got fitter, rehab my physical self, my swallow was always there. And uh, thankfully, I was able to rehabilitate my swallow under Maggie-Lee's guidance. So Maggie-Lee is my hero in a way. And so what that entailed was me going into the clinic and doing biofeedback, low res manometry, where they put a big noodle down my nose and with several sensors, and they can see what was going in there because clearly you can't see your swallow. And Maggie told me, I was slapping my food. So I was a slapper. And so food was going up and down into my stomach. And so with the ability to see my swallow, I was able to resynchronize my swallow into something that is normal, quote unquote, where I could actually go out and enjoy food amongst all the people that that you live with, and I was able to have a beer with my mates, and so and that led me to the picture on the right there, holding a sensor there, where I now work as a patient engagement specialist at Swaltech, and I'm able to apply my lived experience of having a stroke, losing my swallow, and the building of development of the technology, we are able to um, pass on to people to rehabilitate their swallow. So that little sensor in the air is placed um, on my chin, on the patient's chin, and they're able to see their swallow on the iPad. And so to me, that really beats having a noodle shoved down your nose twice a day for 2 weeks. And so obviously my story is really drives my passion to be part of Sorority and to be able to help people again, like I once did in the fire service. And so that's just a brief overview of my journey. Maggie-Lee, back to you.
All right. Thanks, Eric. And yeah, I do remember a time when all you talked about was KFC. What is it called? A double down or a
Double down,
yeah.
yes.
That came up very frequently in conversation, I recall. So a little bit about me. I am old, as you can see in these pictures. In fact, my first picture, still in black and white, but no, it was black and white because it was in a journal article, but it's nonetheless a very youthful me with big hair back in those days. And I started my clinical career in 1980. And back in those days, we thought that the only way to fix swallowing was to make the muscles stronger. And so I started using electrodes over some of the muscles involved in swallowing to give patients feedback about what those muscles were doing. And I started doing that probably not when I first started in clinical practice, but sometime probably in the very late 1980s. That's so long ago. Anyway, and I worked as a clinician for about 18 years in a hospital setting. And then I had a very special patient by the name of Deb, who did a fantastic job with recovery. She went from profound dysphagia to normal eating and drinking in about 4 or 5 months' time. And I decided then I needed to go back and get a PhD so I could understand this problem better and I would know everything. So I got a PhD, which essentially taught me I know absolutely nothing. However, I'm doing my best to learn, and all of that work with biofeedback over the entire course of my career has sort of led to the development of BiSSkApp. And I originally wanted a tool that I could use in research that would help me evaluate how does the brain control swallowing. So we developed this little software tool in the lab called BiSSkApp that I was able to start incorporating into research activity. And then that was consequently made available to clinicians. Seemed like there was enough interest for it, so we just took the big leap and founded a startup company. And so we're trying to make biofeedback modalities that are non-invasive, available to clinicians and patients at a reasonable cost. So that's the big drive of Swaltech, is we want technology that can make a difference. So that's sort of how I've gotten to this point. Now, for today, what we plan on covering are some questions that come up to us fairly often. On those questions, we're going to talk about what is dysphagia. How do you know if you have dysphagia if you're still unsure? What are the impacts of dysphagia on health, well-being, and, indeed on the economy? Dysphagia is a very expensive problem, so it costs a lot of money. We're going to talk briefly about what treatment options are currently available. so that you sort of have an idea of the spread of rehab approaches. And then Eric is going to give you some good practical advice for living with dysphagia and for people that live with you on how they can support you as you work through your process with dysphagia. So that's our plan for today. And I certainly, as we go along, feel free to put any messages in the chat box that Ella is monitoring, and we can either take those questions as they come or we'll deal with them at the end. But either way, please be sure to share your questions as you go along. So let's talk first about what is dysphagia and what things do you need to look for. So, common symptoms of dysphagia, things that you might recognize in yourself if you have dysphagia, is a feeling of the food or drink getting stuck. You feel like it's stuck in your throat and you just can't get it to go through. That's one very common symptom that we hear that patients report to us. Associated with that is feeling like there's food left in the throat after swallowing. So you've swallowed the food, but you didn't get it all down. So you have some that's left over. Frequent coughing, throat clearing, or gagging when you are presented with food. Certainly, coughing and throat clearing would be more common. Or a more common presentation of what we would see. But I do want to emphasize that coughing is not always the best indicator in terms of if you have a cough, that's a problem. If you don't have a cough, that's not a problem. Because we do know that there are many conditions that when you have dysphagia, that you won't have any sensory perception of a cough. So you may have food that goes down into your lungs, but the sensory receptors that would recognize that that's happened aren't working, and so you don't produce a cough. So in many respects, coughing is a sign that you may have dysphagia, but it's also a very positive sign because ultimately that lets you and the clinician that ultimately works with you, if you've got that cough response, then they can be confident when you don't have food going down and when you do. So that can be very helpful in that regard. I'll also comment that coughing, although in many of our stroke patients, that the onset of coughing is fairly abrupt. After you've had your stroke, you have a swallowing problem, and you have episodes of coughing on oral intake. However, if we think again about a patient maybe with Parkinson's disease, coughing may develop very quietly at first, not very frequently, once a week, once every couple of days, you might have a little bit of a cough or a throat clear. And so you don't recognize that as being dysphagia. You just sort of say, oh, yeah, well, I had a little cough, as we all do on occasion. And so that's why it's really important that you listen to your family members, because it's not uncommon at all that we will have patients come in and we'll say, oh, do you have any trouble with your swallowing? And they say, oh, no, 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 not me, not me. And their wife is sitting behind them going, oh, yeah, they do. Yeah, they do. That sometimes family members can more readily recognize your presentation of dysphagia. Listen to the quality of your voice after eating or drinking. And if you sound like you're talking in a fish tank, then you probably got a bit of a swallowing problem. And so a gurgly or wet vocal quality suggests that food has gone where it's not supposed to go, and you haven't been able to clear it out. So you haven't produced a cough response to eject what's gotten where it's not supposed to go. You may have difficulty managing your secretions, usually because of sensory problems. You're not aware that you have secretions there, so you don't just automatically swallow your secretions. And then those secretions either come out as drooling or they go back into the throat. So if you have any difficulty managing secretions, that may suggest more of a sensory problem. And then we certainly would suspect dysphagia if we have someone who has a recurring chest infection, but there's no clear cause. Certainly, if you get a chest infection once, if you're getting on up there in years like I am, and you have one chest infection, you don't think too terribly much about it. But if it happens more than once and you don't understand why, then that really is a strong signal that you need to be thinking about, is this a swallowing problem that needs help? So if you have any of those presentations of a swallowing problem, then you might wind up going to a speech pathologist or a speech therapist who would do an evaluation. And that evaluation, if she's planning rehabilitation, should in most cases include an x-ray that is a picture of your swallowing. So for you, swallowing may be coughing on food or feeling like food is stuck. But for a clinician, when she thinks about dysphagia, it looks like one of these two pictures. Now, this first one does not have dysphagia. And of course, because I want it to, the video is not working. However, if you look at this person on the right, this is a patient with dysphagia. So when he swallows, you can see the food is stuck in his throat. He has some that's going down the front of the throat. And this little white tube here is your trachea that goes down into your lungs. And all of this food is going the wrong direction. And then when he opens up the vocal folds, then some of that food drops down into the lungs. And that's not where we want to see food go. The rest of the food is just kind of stuck in the pharynx, and a little bit is going up into his nose. And so this is a patient with quite significant dysphagia. And a patient like this would have a lot of trouble maintaining an oral diet without effective rehabilitation. So that's why we want to identify this problem and then refer patients for treatment. So, what are the sort of effects of dysphagia? And I'm trying to get the slide to move. Thank you. Okay. Dysphagia can have significant effects on your health and well-being. And we certainly are accruing quite a few statistics that tell us about that. You, as patients or patients' caregivers, will probably know very much about some of these things, others maybe not. One of the problems with dysphagia is that it can produce dehydration and malnutrition. So if you don't drink enough, you become dehydrated. And there are medical conditions that if you become dehydrated, that can cause a lot of problems. You need enough fluid in your body to stay healthy. The other side of that is malnutrition, indicating that you're not getting the right kinds of food into your system in order to provide the caloric intake that you need to thrive. So dehydration and malnutrition may develop slowly and you may not be aware of them, but it would be very important for you to address dysphagia so that those problems don't have an adverse effect. Next one, aspiration pneumonia is a big one, and it's one that we worry very much about. Patients who get food in their lungs, some patients will be able to cough and push it back out if it doesn't go very far down, but many patients are not able to clear. So if you have food that goes down into your lungs and you're not able to expel it, then you're at risk of getting aspiration pneumonia. Not everyone will get pneumonia, and there are things that you can do to inhibit development of pneumonia. There was some research published many years ago that identified the highest predictors of who got sick when they got food in their lungs. Certainly, getting food in the lungs is a problem, but also, funny enough, oral care. If you don't keep your mouth clean and you develop bacteria or other organisms that live in your mouth, then when you swallow, if you get food in your lungs, it's not only the food going into your lungs, it's the bacteria from the mouth. So it's very important if you have a swallowing problem that you keep your mouth very, very clean. Another issue that contributes to development of pneumonia is if you don't move. It's really important that you keep yourself mobile. You walk to the post box once or twice a day so that you're keeping your pulmonary system moving, and that improves its ability to keep things clear. So there are quite a few things that we can diminish the risk of pneumonia because it's important. There's one study that's documented that in stroke patients, 25% may die within the first month, 50% within the first year without effective treatment. And I want to emphasize the without effective treatment. That's quite a grim statistic, and it's one that we need to pay attention to, but we can provide treatment that can offset that risk. Um, Dysphagia can have a big effect on getting medications in. Can you take medications orally? If you have a lot of trouble swallowing, you may not be able to take them orally. So we need to figure out how to get blood pressure medicine in you, particularly if you're a stroke patient or in Parkinson's disease. Then you may need a route to get your meds in for your Parkinson's disease. So medication difficulties are quite significant. I'm going to pass over to Eric to talk about the more um, personal social issues that may come about because he certainly experienced those.
Oh, thanks, frankly. So social isolation, anxiety, and depression, they kind of interlink there. Um, like I spoke before, I did feel anxious to even put food in my mouth to because I'm worried that I'm just gonna end up choking on it, and so um, I just it built up of me, and then from that depression really got to me because of not not knowing what to do. You know, I'm choking on all these things, and um, I wasn't able to have something, have someone to really provide help. So the social isolation there is really, from my point of view, was being separated from family, friends, not being able to eat in front of them because they're as family do, they always want to talk to you, and you're only human. You try and talk back, and there you go, you start choking on your food. And so that just built up the anxiety and therefore the depression of no going out to see your friends or your family members. So, yeah, that's me.
Yeah, I'll just add one sort of clinical story or one exposure I had as a very young clinician that sort of ties into this, and it's the isolation issue. At the time I was working with children, and I had a young child who, by recollection, was maybe 4 years old or so. And he had had some birth injury and had some disabilities associated with that. I was going to his home at about 5 o'clock in the evening one day to visit he and his mother for a session. And when I got there, the family was sitting around the dinner table. So it was the mom and two older siblings and a grandmother all sitting around the dinner table chatting, having their meal. And I asked, well, where's Joe? And they said, he's in the back bedroom. We put him in the bedroom while we have meals because we don't want to hurt his feelings by eating in front of him. And I guess that's had such an effect on me because I think food is so important to us socially, as Eric has said. And when you take a 4-year-old and you don't include them in meals, not only are they losing that social engagement with family, the only time everybody's together and sitting around the table together, but they're also losing that language learning. And so I think it's really important that we recognize across the age span, from our very, very young to our very, very old, it's really important that we stay engaged. And engagement around meals is a very natural way to do that. So whether it's a 4-year-old child or whether it's a 92-year-old grandfather, who maybe isn't as clear in his thinking, having him sit at the dinner table and eat his dinner is going to give him that grounding of being able to communicate with people that he knows. So just to pass on that story, and maybe that will kind of stick with you, I suppose. Really important to keep eating together because we love to eat and drink. Golly, I love to eat and drink. So, what are our options for treatment? We do have some options for treatment, and I would say that over the past 5 or 10 years, those options are really on an upturn. That now that we understand the nature of dysphagia better, we can come up with treatment options that actually fit the problem. So, very first thing that you need to do if you're concerned that you have a swallowing problem is go find a speech and language pathologist or speech and language therapist. Those are the specialists that tend to work specifically with swallowing. And so go and seek that kind of support so they can do a full evaluation and come up with a treatment plan that suits you. Those treatment plans may consist of quite a few things. Certainly, a way to make you safer in the short term while you have a rehabilitation program is to give you compensatory approaches. So, compensations are much like if you broke your leg, you would have crutches to help you walk until your leg healed. So the crutches are a compensation for the broken leg. And when we look at our compensation techniques, that's what they are as well. While you undergo rehabilitation, you need some things to keep you safe in the meantime. So that might consist of a postural change. If you drop your chin when you swallow, or if you turn your head to the side when you swallow, those sorts of postural changes may help direct the food to the right part of the pharynx where it's going to be swallowed more efficiently. You may be prescribed thickened fluids or softer foods, pureeing your foods, so that your meals are a texture that is theoretically easier to get through the pharynx and down into the esophagus. The literature on the effectiveness of particularly thickened fluids, if you look at the research, it's a little bit debatable if they actually are producing the positive effect that we might have thought they were in years gone past. I think you really need to balance adjustment in diet with quality of life. That drinking a thickened fluid all the time, if you don't like thickened fluid, that can have a real effect on your quality of life and your willingness to want to eat in front of people. Same with pureed foods. Having a mound of food, a mound of chicken rather than a chicken breast or a chicken leg, is a very different thing. So, nonetheless, thickened fluids and pureed foods are very often recommended as compensatory approaches. And then there may be behavioral strategies, like things that you can do to be safer. That may be taking smaller bites. So, taking your time when you eat with little bites that you think you're able to manage and get through your throat, or many other strategies along those lines. And your speech and language therapist has many of those compensatory approaches in their toolkit that when they look at your swallowing specifically, they can decide which strategies would best help you. Then, as you're doing those compensatory strategies to stay healthier, we could also do rehabilitation approaches, and we know so much more now about rehab than we have in the past. In our early days of working in dysphagia, when I started in clinical practice, back when I had the big hair, the big poofy hair, back in those days, we thought swallowing was a reflex. And so all we could do to facilitate improved swallowing was to try to make the muscles stronger. And so we came up with many exercises where you would do things, the equivalent of lifting weights for your throat, that your main focus would be to make the muscles of the oral cavity or the pharyngeal cavity, make those muscles stronger, with the idea that when you swallowed, it would push the food through the throat more effectively. So we have many muscle strengthening exercises. Some of those are non-specific. They strengthen sort of everything all at once. Others are very specific. They only strengthen the muscles underneath your chin, for example. So we've got an abundance of those approaches that some have a lot of literature to support them. Some have very little literature to support them. So that's one approach, is to work on targeting the strength in muscles. More recently, we have recognized that swallowing actually isn't so much a reflex when you're eating food, that it's a very skilled motor task. And so there's a whole new area of rehab development over, say, the past 5 to 10 years that is focused on skill training. And these are exercises that have been developed to target how the brain controls the muscles or controls the execution of swallowing. So you're not working on making muscles making muscles stronger. You're working on how do those muscles move to make swallowing more efficient. An example of that, Eric spoke about when he was still dysphagic and he would come in for treatment, that he had a problem with his muscles of squeezing the top muscles. Generally, you want to squeeze the top muscles first, followed by the bottom muscles. But Eric was, as he says, I said, he was slapping the bolus. So that's a motor planning problem. And if we work on strengthening, instead of improving swallows, it just means that instead of pushing this hard, he's pushing this hard. And that's going to push a lot of food up in the nose, more food down in the airway if he can't protect his airway. So it's not the right treatment approach. What we need to work on is the skill of controlling how those muscles work. So squeezing from the top to the bottom and doing that efficiently and effectively. There are other approaches that have been published in the literature about coordinating your swallowing better with your breathing, that we know that the best place to swallow is right as you start to breathe out. So then you close the airway and you swallow, and then you continue to breathe out. That's a skill. And in some patients, that skill is impaired. So we need to work on the skill, not on strength. So the whole focus is delineating how much of the patient's problem is due to weakness and how much of the patient's problem is due to poor skill. Again, if we think about Parkinson's disease, Parkinson's usually isn't a disorder of strength, it's a disorder of skill. BiSSkApp, the product that is being put out by Swaltech, is our solution to intensive skill-based swallowing training. So now I'm going to shift back and let Eric sort of wrap us up. We're getting close to the end here and give you some practical advice. So take it away, Eric.
Oh, thanks, Maggie-Lee. So, as Maggie-Lee spoke about before, friends and family are pinnacle to your rehabilitation. Take them along, and they're an extra pair of ears to hear what specialists are saying. The amount of times I've taken my partner just to a doctor's appointment, and I've just totally read uh, what the doctor was saying, so that they're there. Just use them, and they love doing it as well. And they also are pinnacle in observing changes that you go through day to day. And so, how to prepare for success. And as I said before, the friends and family will help you with their to monitor that. But also, a big thing for me after having a stroke was fatigue. And how do you measure that? You can't see it. So the best way I did it was uh, come up with a fatigue diary where I would take note when I would get fatigue, for how long, and also take note on what I ate during that time. And then you're able to plan your day around your bad times during the day, around your fatigue, and you can also plan your meals around that as well, because you want your swallow to be tip top when you're putting food down. So fatigue will play a big part of that, and knowing when to do it. So compensation toolkit is a kind of learning with your friends, your family, and clinician. For me, one of those things was not sleeping on my back, because I'd wake up drowning in my own secretions, and that's scary. So I just sleep on my side. And so you would work out the best ways for you to live a great life, to get that sleep that you always want. And so and then once you do it, it becomes a routine, and from there it becomes a habit. And so for me, even though my swallow is pretty darn good, not 100%, but I still have these compensatory. Sorry, I can't enunciate that properly. These things that I do to prepare for success: sitting upright, sitting at a table, and taking smaller bites. Things like that is it's just a habit for me now. And also, Maggie-Lee spoke about pneumonia and how that can be affect you as well. And I've learned to compensate by keeping fit, really keeping the cardio happening, and so you got a bigger lung full of breath. So, and that's all part of these things that help you swallow better. So exercise is really good also for mental health and all that. So if you're feeling tip shape, then your swallow is good too. And so how BiSSkApp fits is so it's just like going to the gym, having a workout for your swallow. It's right there beside you. You got it at home, so you don't actually have to get up, drive, change. I don't. Sorry, you probably get changed before you drive, not during it or after. But you go to the gym, and it's quite a big effort. But if you got the gym right next to you, well, hey, you just lift up BiSSkApp, have a session, and you're good to go. And that's what I love about it. You don't need to travel to the gym or a clinic, so to speak. So these are some things that have helped me, but you can apply yourself as keeping fit. Um, Use your friends and family. They love to use. So use them. Take them along to your doctor's appointments. And, if they say, hey, you're choking on your coffee more often than usual, that's a sign, take it on. And it's hard being a bloke. And man, what does Jess know about it? But hey, that's what they're there for. They see things that you don't. And so that's me. Back to you, Maggie-Lee.
Very good, Eric. Thanks for that. And I think we're turning over to Ella at this point. So
Beautiful. I'm just trying to find it where in my settings I can turn on
turn the
the.
camera to you.
Hi, everyone.
There she is.
If we move over questions, feel free to put some messages in the chat, or there's a particular Q&A bubble there, but I can also change the settings in case anyone wants to just shout out on the chat as
Yeah.
well. Here we go.
I like just shouting out.
Beautiful. So you should now be able to turn on your microphone and your camera if you want to speak in the chat. Otherwise, the Q&A or the chat is where you go. This is from Joanna. Hi. In Parkinson's disease, if swallowing difficulties are minimal in the early stages and the primary focus is on strength-based voice exercises, should this skill-based app be implemented preventatively, or is it more appropriate to wait until swallowing symptoms become more evident?
That is the best research question. And if I weren't as old as I am, I would be starting this project right now. I think it's such a good question if you can essentially do prophylactic rehab with Parkinson's disease. So you start working on strengthening the neural pathways associated with swallowing by doing some skill-based training. And if you do that over and over now, if you essentially, as Eric said, start going to the gym early on when you still have pretty good function, will you maintain that function longer so that the delay of dysphagic symptoms is further out in disease progression? And that is a really, really good question that nobody knows the answer to. But I guess if I were a patient and I were diagnosed with Parkinson's disease, that's what I would want to do. It wouldn't be evidence-based at this point in time, but I would do it anyway because it makes sense.
Beautiful. Had a couple questions.
That's so helpful.
Good. Thanks.
A couple of questions in the chat that I think the team have addressed really well, but if you're a patient, if you're a clinician, if you're interested in a rehab system like BiSSkApp, you can go to our website and either book a call with us where we can chat you through what that would look like, what the options are. We can also, if you're a patient and you're not currently seeing a speech and language pathologist or therapist, we can connect you with someone who is already using our system. Any other questions in the chat or the Q&A about dysphagia, different care options? Looks like no. Well, I just wanted to say thank you again to everyone who has joined us today. And we will be putting this up on our YouTube channel if you want to revisit any of these points. And yeah, please, we'd love to connect with you if you have any questions or more.
You're welcome, Katie. Thanks for coming.
Thanks, team. Really enjoyed the patient perspective.
Very good.
Thanks so much.